My name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. Thank you for joining us for today's Upper Midwest Telehealth Resource Center webinar. We have Genoa Telepsychiatry with us today, and we'll be talking to Parker Cunningham from their business development team, Robin Shapiro, who helps with the upfront design, and Chetan Khanna with customer success. So without further ado, I'm going to go ahead and hand it over to these guys.
All right. Thank you. I appreciate the brief intro there. As they said, there will be a team of 3 today helping me lead this presentation. We'll go ahead and get started here and lay out the agenda, but I appreciate your time first. So today's presentation is about building sustainable telepsychiatry programs. As you all are well aware, there's a national shortage of psychiatrists, and as a result, this places importance on creating access to psychiatrists. So one key way to increase access, particularly in rural areas where access is likely most challenging, is through telepsychiatry. So I'm going to walk everyone through this presentation on telepsychiatry and how we've built sustainable programs. I hope the attendees today can walk away with an understanding of the fundamental elements that make up telepsychiatry programs and that make them sustainable. So we'll go ahead and get started here. We'll start with the agenda today. I'll first discuss the scope of our programs and take a deep dive into a case study. We'll then explore the telepsychiatry model and how its design lends itself to building sustainable programs. We'll then move on to discuss each stakeholder in a telepsychiatry program, and then how each stakeholder can capitalize and measure the benefits of telepsychiatry. And we'll then go on and look at some of the codified processes and the infrastructure necessary for the implementation of telepsychiatry programs and to keep these sustainable and ongoing. In moving on, so just a brief introduction of who Genoa Telepsychiatry is. We've been around for 6 years, and telepsychiatry in general is a relatively new field. So in a new field, we're a pretty old player. We've treated over 50,000 patients over our 6-year history. We have a geographic footprint, about 20 states, with a number of other states that are implementing. We've really ran behavioral health and telepsychiatry programs in all kinds of behavioral health settings. So in inpatient units, emergency departments, community mental health centers, primary care settings, FQHCs, you name it. In terms of where behavioral health care is placed, telepsychiatry programs can be feasible. These services are conducted over a HIPAA-compliant video conferencing software. This software can include some unique tools such as scheduler notes, prescriptions, and so on. Go ahead and give a little bit of an overview as to how we got here. We were once upon a time known as One Doc Way. Once we were acquired in November of 2015 by Genoa. Genoa is the parent company, and I'll be brief in this regard. They are a behavioral health pharmacy. With a significant number of pharmacies located at community mental health centers. There's around 300 locations across over 40 states. And they acquired us again in 2015 to add a telepsychiatry division. So with the introduction there out of the way, we'll go ahead and move on to the telepsychiatry case study. First, I want to point out that the graph on the left just shows the number of patient visits on our telepsychiatry platform throughout the course of the last 4 years. So it's key here to see the exponential and sustainable growth, which at a high level really reflects the sustainability of our programs. This is the course of the last 4 years, and you can see the number of visits has really climbed. On the right side, we can see the weekly number of appointments created. This goes hand in hand with the graph on the left. They both demonstrate that the growth and sustainability is possible with telepsychiatry, even in the snapshot of 4 years. So, simply put, You see this type of growth in sustainable programs where the incentives are aligned between all the stakeholders participating in these programs and when the right model design is in place. And these are components that we're going to discuss a little bit later on in the webinar. And moving on, we're going to look at, as I just alluded to, the model design. This I really want to hone in on, as this is really central and at the core of sustainability for our programs. It's important to recognize here that our model design that we've came up with for telepsychiatry can be applied more broadly to all the types of clinical settings that you see in front of you, such as a CMHC, an FQHC, a critical access hospital, and et cetera. At the root of the programs, it's really the model design that truly makes these programs sustainable. So in touching a bit more on the design, the theme here is that by seamlessly integrating our providers, our telepsychiatrists, into remote clinics workflows, both operational, clinical, we're able to use the clinic's existing infrastructure to support the program. And we remain active in refining the program, but by placing a telepsychiatrist and remotely integrating them into an on-site care team, we can really create sustainable programs and in turn align the stakeholders in the right manner. We'll go ahead now and take a little bit of a deeper look. I'll take a pause here so the attendees can take a look at the metrics laid out. It's important here to evaluate just some of the metrics we collected. On a high level, these are the type of metrics that we want to see when measuring the success of a telepsychiatry program. Some highlights are looking at the significant reduction in wait times to see a psychiatrist. So, patients are now from this case study, patients are now waiting 2 weeks as opposed to 6 weeks. We see greater accessibility by placing a psychiatrist in closer proximity to these rural patients. In addition, we're seeing with the right utilization of a psychiatrist, our care partners can even turn a small margin from a telepsychiatry program. In this case, I believe it's around $21 per hour. The high level takeaway, when you look at each of these stakeholders involved, outlined 1 to 4 here, is that when they're appropriately incentivized, these stakeholders, they can really drive the program forward. It's also just as tantamount as how we measure these types of metrics. And these type of metrics really are a testament to sustainability. So when designing these programs, it's always key to keep in mind how we can come up with a system to measure the sustainability. And that's for each stakeholder. Go ahead and move on now to the, I know this slide's a little wordy here, so I'll take a high level, but I want to show how this model design that we just alluded to and the associated stakeholders can be applied more broadly. The story here is really to demonstrate how much impact we can have if we run these programs in a sustainable manner. I mean, you see big figures here: 35,000 underserved care facilities, 80 million plus patients, 45,000 plus physicians in this marketplace. So the key here is how we can apply our model design more broadly to this broader market, and how telepsychiatry can be an answer to addressing accessibility challenges. So, regardless of the patient population, telepsychiatry can be an answer to address it, to address this accessibility challenge. Some of the particular incentives that I wanted to highlight from this slide and reinforce are increasing access to psychiatrists. I mean, that's an underlying theme, right, of telepsychiatry. It's the root of our programs and for our care partners and their patients, most importantly. For our providers, there are many incentives. Some of the most common themes we see are improving lifestyle and satisfying, the desire to deliver care to these underserved patient populations, which many of our clinicians do. And lastly, I'd say, and perhaps most importantly, is the benefit to our patients, where we can really enable greater access. Even that was alluded in the previous slide of cutting down 6 weeks to 2 weeks and cutting down the driving distance time to access a psychiatrist. We really do enable greater access, and then in turn, you prevent illnesses from progressing downstream, and in turn control those costs. So just from a high level, these are some of the positive incentives for each stakeholder that participates in a telepsychiatry program. I'll move on, as we move forward from the individual stakeholders. I want to take a moment to present how the model of telepsychiatry fits into the marketplace today, and some key themes to recognize within this slide that just support the general theme of sustainability. In general, and from a market perspective, we're addressing patients that do not have adequate access to care. We are bringing together the supply of providers to the demand of the clinics. In fact, in a figure that's left off the slide, but in fact, about 83% of our patients were not seeing a psychiatrist before they visited one in our telepsychiatry programs. That's a really astounding figure. Again, 83% of patients were not seeing a psychiatrist prior. And more so to the model here, which what the slide gets at, it's essential to recognize how our model addresses this marketplace, how it addresses the supply and demand match. The most essential piece to this model is the alignment of a provider and remote clinic. So we want to ensure that there's a strong cultural fit here. There's a philosophy of care alignment, just with stylistic preferences between the provider and between the clinic. In addition, we want to ensure there's logistical alignment in terms of appointment durations, whether med management or initial evaluation, through schedules, through clinical workflows. Once these variables are fleshed out, and the transparent expectations are laid out between the clinic and the provider, we can start setting the program in motion. And lastly, I think as I've noted, throughout the last few slides, a key piece to achieving sustainability is the notion of developing these data-driven system to really measure the metrics. We want to make sure we have a system in place that can encourage repetition. So you look at wait time reductions, provider utilization, satisfaction outcomes. These are the reports that you want to see after X amount of months in a telepsychiatry program that's showing sustainability and that's showing growth, and really encouraging telepsychiatry partnerships. I'll go ahead and move on to the partnering facilities. So these are really focusing on our clinics, and this is really useful data. It captures data that evidences the growth of our clinic partners, which is really a testament to the sustainability that this model enables for our clinics. We can see on the left that on average, partnering clinics increase usage of telepsychiatry services by about 47% year to year. This is a really significant number. And we can see here that the average clinic was starting on the left side of the graph on the left with about 8 hours a week, and grew the program to about 18 hours a week. And this number continues to climb. We can also see a snapshot of more clinic growth on the chart on the right side of the slide. It's important here to look really, I think, at that far right column, where we can see, seeing significant growth in monthly hours of telepsychiatry per clinic. In all, this type of growth is feasible for all clinics that structure a telepsychiatry program the right way. So again, it's driving home that thesis that for the clinics, the clinic stakeholders here can really build sustainable programs, and we have evidence, data-driven evidence of growth of these programs for clinics to participate. And moving on, moving away from the incentives for our clinic partners and for the clinics themselves, we can also see data supporting the incentives for our patients. And perhaps most importantly here, we see that the patients on average are seeing our providers 5 times, and they're also about 85% of our visits are follow-up visits. This is a real testament to the patient buy-in to the program. It's also, which is sometimes a concern, and I think it alleviates the concern, is a testament to the relationship that the providers are able to build with these patients through telepsychiatry. Patients are commonly returning to see their telepsychiatry provider. I mean, these numbers of 85% visits being follow-ups, and the average patients average about 5 visits during treatment. Really speak to that rapport that's built, and speak to the patient buy-in to a telepsychiatry program. And on the last note, in terms of the doctor incentives, as we start thinking about, we've discussed the clinic incentives and their stakeholders, is how there's growth in telepsychiatry programs, and then also how patients are returning to take part in telepsychiatry programs. We're also wanted to make sure that the final stakeholder in this mix, the physicians and the providers themselves, are also demonstrating that same theme of growth, and ultimately contributing to sustainable telepsychiatry programs. So, here we're noticing on the left that doctors increase their number of monthly appointments by about 11%. A lot of the motivation behind this growth is really summarized by the bullet points on the right, where the no-show risk is off their shoulders. So there's guaranteed pay. They can design their own schedule. They can work from home and have flexible hours. Just to encapsulate, these are the motivations that we see of how doctors grow with our program. They can also treat underserved patient populations here. When you have these different stakeholders, as I've alluded to throughout the presentation, between doctors, between clinics, you really get utilization and can build sustainable telepsychiatry programs. Go ahead and carry on to, the last slide here is how we capture the telepsychiatry benefits. So this is why we build programs, just simply put. These are some of the key takeaways. We want to improve the access, as I alluded to. We wanted to deliver the clinical benefits and create this mental health care for patients, and a continuity within our system where they're seeing the same provider over and over again, and there's an established continuity of care. And then in addition, there has to be an incentive for the clinics to buy in. Again, this reflects back to the data that we showed, that clinics are increasing their time with us about 47% year over year, and then also, turning a small margin for their organization. So with these reasons, these are really the building blocks of these telepsychiatry programs. With that said, I'd like to pause here and open up to Q&A and see if any of the audience members have any Q&A. I'm happy to go back and backtrack to slides where we like to dig a little deeper. But at this time, we can turn it over to Q&A, and also introduce my colleagues with me, Robin Shapiro and Chetan Khanna.
This is the time for you to go ahead and use the Q&A function to ask your questions. We did have a question, what software platform are you all using? And I'm not sure if they were trying to ask what we're using for the webinar today, or if they were trying to ask what software platform you guys use there at Genoa.
Yeah, absolutely. So I can go ahead and answer that for you. So in terms of the software platform that we use for telepsych, that is the one doc way telepsychiatry platform, and it is HIPAA compliant, as Parker had noted, and that has both the video portion in which the patient and the provider in the clinic can enter into an appointment to have the patient seen, as well as a fully functional EMR, as well as an e-prescribing software built in. And so that's kind of what we use for telepsych. And in certain cases, in most cases, we'll have the provider documenting within our EHR, but in some cases, we'll have the provider documenting in the EHR for the clinic.
Thank you. And that OneDocWay software is proprietary, right?
And in terms of, if we were to work with the clinic, we generally allow for unlimited licenses. So you're not paying per user. You generally, as many staff members as required that need to be using the platform are generally allowed to use it. And there's no additional cost in terms of, the implementing process.
So our next question is the patient connecting to the visit from their home or at a clinic?
I can take that one. This is Robin Shapiro. I'm a registered nurse. I formerly managed a large psychiatric unit. The patient is connecting from a clinic. Typically, the individual would go to receive telepsych care from the clinic that they're familiar with. So the workflow would go something like this. The individual would make an appointment. They would come to the facility where they're very comfortable. They know the staff. They would come in, they'd be greeted. They would have their vital signs taken and ushered into a dedicated room where they would have their telepsychiatry session. They would the medical assistant would get them on within nanoseconds to the platform, and they would be able to see our telepsychiatrist for the comprehensive psych evaluation, medication evaluation, and management.
Thank you very much.
Sure.
Another question, who handles callbacks for patients after working a shift?
I can take that. I'm not sure I fully understand the question, but in terms of scheduling for the patients, that would be done by the clinic staff. So both in terms of when there's an initial appointment, the staff would schedule that appointment, and then they would be the ones starting it and bringing the patient in. When they begin the telepsychiatry appointment with their provider, and then once the appointment is done, the clinic would also be responsible for scheduling any additional follow-ups.
One point that's worthy of noting is that patients are seen consistently by the same provider to foster the development of that trusting therapeutic relationship and facilitate continuity of care. And as Parker mentioned, 85% of the visits that are currently conducted are indeed follow-up appointments.
Mm-hmm. So there's clarification on that question. So if the patient needs medication changes, will they go back and see the psychiatrist again, or will they see someone else within the staff?
They will see the same psychiatrist that ordered the medication initially.
And then you already answered the question about patients are normally at a clinic, and I know reimbursement varies. In the states that we cover with the Upper Midwest Telehealth Resource Center, Illinois, Indiana, Michigan, and Ohio, depending on the insurance that is being billed for the visit, there are really not, unless it's a private pay, no one is reimbursing if the patient is at home. Are there any other states where you guys are seeing patients at home?
So there are. We are working with patients at home, I think in California with a particular payer. But as the person outlined, the trend for at-home care is, I think, in the early stages. Right now, and where telepsychiatry field is headed, and where the vast majority of our operations are at the clinic, and that's largely due where the health insurance company, the payer, will reimburse. So to answer your question, yes, we do have a direct-to-consumer model that addresses patient care at home, but the vast majority of the operations are done at clinics where reimbursement is established.
Great, thank you. What other questions do we have from the audience today? I know this is Becky Sanders again, one of the big things that we've been working on in the state of Indiana is school clinic programs. And I know that there's some research being done both in Ohio and in Illinois at this point to set up those particular programs. And there are some school programs in Michigan that I'm aware of. Have you guys been involved in any school programs?
I have not yet been involved in school programs. Parker?
Yeah, I don't think we have school programs up and running. That's not to say they're not feasible, but again, it's really built around the concept of reimbursement, right? The payer is a key stakeholder, or not even a stakeholder in this regard, but it can be considered a key stakeholder in this regard, and certainly enables a program to be feasible. So if reimbursement is feasible at a school setting, then it's certainly feasible to set up a telepsychiatry program. We have not developed, I believe, to date a relationship at a school program, but it's certainly feasible if reimbursement is there.
And for any additional questions, just so that we can better answer, it'd be great if the person asking could maybe just provide their name and organization so that we kind of know where you're coming from. Because right now it comes up as anonymous for us. I guess if you're comfortable.
Okay, this is Becky again. We did have someone raise their hand. We don't really have a way to open up the audio lines for those that want to ask questions. They'll need to be asked through the Q&A feature. If there are other questions that for some reason you can't use the Q&A feature, you can email them to me at B for Becky, Sanders, Sanders, at Indiana, like the state, and then rha.org. I've got another question. The Rural Health Association, we had our public policy forum yesterday, and one of the hospitals in our state came up to me, and they're trying to they've got an inpatient unit, but they also want to do some outpatient work, and they're trying to figure out what's the best way to go about starting up a program.
Oh, would that be outpatient overall or outpatient telepsych?
A telepsych.
Yeah. So I mean, I guess I can jump in there. I think in terms of the best way to get started, I think there's a lot of steps that go into that. But in terms of our general workflow, like Robin had kind of outlined, the overall needs for telepsych is that there's someone available to schedule appointments. There's a medical assistant available to take vitals and introduce the patient into the appointment. And then, similarly at the end of the appointment to follow up with the telepsych provider on any updates, as well as kind of schedule the patient for any sort of follow-ups. And so, in general, we at least require, the person who's a medical assistant can also be in charge of scheduling, but usually that's kind of having someone available for that, as well as a room designated for telepsych, are like the kind of minimum requirements needed for telepsych. And that's something that's very nice about it, is that it can be done pretty bare bones and pretty versatile, I guess, in a very versatile fashion.
Thank you.
This might be a good time to mention that with respect to equipment, all that's really required to run a successful program would be a laptop computer or a desktop computer with a webcam and a high-speed internet access. We don't require any expensive capital equipment. So for a facility that doesn't have, a big capital equipment budget, they don't need to worry because that's not essential.
Thank you. Good point. And just because my background is in telecommunications, I have to ask, what do you consider a high-speed broadband connection?
Yeah, so our minimum requirement is 3 Mbps upload and download, but we generally recommend 5 upload and download as what's going to be ideal for a smooth video quality in terms of both audio and video.
Thank you. We have a question from Kimberly Poland. Have you noticed an improvement in the level of disclosure of the patient provider since it's not a non-face-to-face experience? I'm sorry, the level of disclosure that the patient provides during the visit being not face-to-face versus if they were face-to-face with a provider?
Yeah, I'm happy to jump in here, unless I guess we have the Parker. Do you want to go in first? All right. So yeah. So I mean, in terms of on our end, so we've generally noticed that obviously there is an initial maybe I guess hump to get over in terms of just quickly adjusting to the telepsych experience, but that usually can happen within the first few minutes of an appointment, that a patient kind of gets used to it, and especially in the way that we have it set up, where a patient would be in what's called kiosk mode, where the computer is full screen and they can't leave it. It honestly does feel like a normal appointment for most patients. But it's also something that we're working on in terms of our account management team, as well as our implementation team, works with our providers to kind of develop what we call webside manner, which is just being accustomed to the fact that you are kind of providing services over over webcam. So kind of just adjusting your facial expressions, your overall body language, and how you kind of transition between documenting notes and looking at the patient, so that in terms of how they interface with the computer, it feels as though they're in that room for the patient. And then, like Parker had said, we're often collecting data on patient outcomes and constantly in communication with the clinical staff to make sure that, in terms of high quality of care over web platform, that the patients are getting the experience that they're looking for. So, we obviously have kind of processes in place to try and maximize that right from the start, but it's constantly something that we're improving on, on a clinic per clinic basis.
Sure. And just to add there, from a high level, we have data on the screen there where journal articles have outlined just telepsychiatry being just as effective and safe as in-person consultations, where there is, equivalence between clinical outcomes from telepsychiatry to in-person consultations. There's now a large database of literature that supports that. One of the things that I think Chayton just outlined, and just from a high level to recap on, is that we do work alongside to develop best practices for telemental health that are outlined by the American Telemedicine Association. So there's a lot of thinkers in this regard that are at the forefront of making sure those consultations can echo in-person consultations, can really feel like the same. And, the data is there to support it, but it's also key for us to constantly refine that process, as Chayton alluded to, and create an environment in a consultation that feels like an in-person consultation.
And all of these well-designed clinical studies aside that demonstrate the clinical equivalency, what's really the more important factor is patient comfort. And from everything that we hear, patients are very, very comfortable with their telepsychiatrists. And again, going back to that 85% statistic about follow-up visits, that demonstrates to us anyway that patients develop that trusting therapeutic rapport and they come back for treatment. And when faced with the choice of being able to schedule an appointment within just a matter of days, or being referred out, if they can even get an appointment, instead of driving hours to, a provider that may be, many, many miles away, and getting an appointment within, 12 weeks, the choice is very clear. Patients will choose to come in for a telepsych visit. Initially, they may have, some questions about it, but within just a matter of a few minutes, as Shay mentioned, they're very comfortable and the visit proceeds just like any other. And from a clinical perspective, anything that a provider can assess during a face-to-face visit, they can assess during a telepsych visit as well.
Thank you. I've also heard, this is Becky Sanders again, I've also heard some just colloquial stories of patients that actually feel more comfortable and they have a larger level of disclosure with the provider during a video conference meeting, because somehow it feels a little bit more anonymous.
Becky, I think that's a great point. When I have been in rural settings, one thing comes up time and time again, and that is that the individual getting treatment, look, there still is a stigma in some areas about mental health care, and there's a comfort level being able to receive treatment, knowing that that individual will not run into their provider at the local supermarket or movie theater. So from that perspective, there is that privacy and that comfort level that they can get the care and the treatment they need without that concern. So from that perspective, they feel much more comfortable.
Great. So what other questions do we have from the audience today? We have just a few minutes left.
Becky, I'm wondering, may I ask a question?
Sure.
I'm wondering if anybody in the audience would be open to sharing a success story that they've had with telepsychiatry in their facility.
Sure, absolutely. Type away. And then I have a question. I think I remember the answer to this one, but I'll ask it anyway. When you guys, when Genoa sets up a psychiatric relationship with a clinic or a hospital, do you always provide your own psychiatrists, or how does that work?
That's a great question. What we like to do typically is, because most facilities have a shortage of psychiatrists, we will bring in our own. However, if there are some part-time psychiatrists or a couple of psychiatrists on staff, if they would like to participate, that's great. We welcome them. One point that I'd like to mention is that we have a terrific physician partnership team that coordinates video conferences once they find great psychiatrists that they believe will be a strong match. And what that really does is it enables the providers and the clinics to get acquainted and to make sure that everybody is looking in the same direction. And so the selection process really allows the clinics to interview and choose psychiatrists or APRNs to make sure that they will assimilate well into the organization and culture and share a similar prescribing philosophy. Has anybody responded with a success story yet, Becky?
We have one person, Kimberly Poland, who says, we have selected a vendor that provides both EMR and telehealth technology and looking forward to rolling out that program soon.
Okay, that's a first step. Were there any other questions?
Not at this time. Excuse me. Here's another one. Our organization has telemedicine set up at one of our clinics and has recently expanded to offer psych consults in one of the internal medicine clinics. So patients come into what's called an advanced care center, and instead of having to have separate visits, the patient virtually connects to the psychiatrist. That's been a very popular model. Thank you for sharing that, Taylor Collins. And that helps again with the fear of being noticed at a psychiatrist's office.
Thank you for sharing that, Taylor. And in addition, that does integrate primary care with behavioral services. I know that I've heard the estimate that anywhere from 45 to 60% of all individuals that present to primary care have a co-occurring psychiatric condition as well.
Mm-hmm. Yeah, this is Becky again. Leaving politics aside, I think that you will see more movement in mental health and more focus on mental health going forward, with more, how do I want to say this, more focus on including mental health as part of the whole sense of self and health of the person as a full individual. All right, last call for questions. Anyone else want to share where they're at in their day-to-day practices? I like what you said, Robin, about some part-time psychiatrists. Some of the studies, people in my organization have been involved in workforce studies here in the state of Indiana, and we found that if you take the whole state and and I don't remember the numbers off the top of my head, the number of psychiatrists versus the population, and you divide that out, I think it's one psychiatrist per 1,000 people or something like that. Does that sound right? You take that number over the entire state's population, we don't have a shortage of psychiatrists. But when you focus on the difference between urban and rural, you see that there's a disproportionate amount of psychiatrists in urban settings and not in rural settings. So telepsychiatry helps to even that out over rural populations.
That's exactly right, Becky. And that's why telepsychiatry is a viable solution to several problems that we're seeing. And, you know, it's a great way to meet the triple aim that we're all striving for.
Mm-hmm. Thanks, Robin. We do have another question. When Genoa provides the telepsychiatry platform, who is doing the billing for the clinic?
Yeah, sure. So happy to address that one. Thanks for the question. We see the clinic do the billing, and there's a couple reasons around that. One is the infrastructure is already in place. We want to mimic that existing workflow in place. If a clinic already has a billing practice set up, then to mimic that workflow, it makes sense. It also to align the stakeholders there. For the clinic doing the billing, there's an incentive for the clinic and the provider to get utilization, right? The backbone and really the root, as I noted, to the success of these programs is utilization on behalf of the provider. So we always encourage clinics to select a demand or select an hour total that they feel comfortable with and that they could address, and that the provider could address, and where utilization would be there. We understand often with these populations that no-show rates can be high, varying per the acuity of the population. But the clinics, to recap, the clinics do the billing here, and we see that often incentivizes the utilization of these programs and really helps form healthy partnerships here.
Thank you. Kind of a follow-up to that was within that question, are there certain requirements? And I'm wondering if what the person is asking is certain requirements about the way that they bill. When you bill for a telemedicine event, you want to put a GT modifier in front of your normal office visit code that you bill. That is the industry standard at this point. There has been some talk about a 9.5 or some other qualifiers, but right now by putting that GT in front of that, then you're the entity that you are billing for reimbursement will know that that happened via telemedicine.
Exactly. And just to add there, Becky, on top of the GT modifier, there's also a Qcode that's capable of being billed as well. It's a Q3014 code, which is a facility fee. This is essentially incentivizing the adoption of telemedicine. Now, this isn't not every payer is reimbursing for this fee, but the trend is and has been over the course of the last few years of adopting that Q code and incentivizing the adoption of telemedicine. It ranges between $15 to $25 on average per patient encounter. Which really, if you see 3 patients an hour, that's an additional $45 in revenue. So it's a very sizable chunk, and it's often incentivizing these programs and allowing them to really be financially feasible. Again, the Q code, it's per payer. In some states, it's mandated. In other states, it's not. It does vary. But nonetheless, for a lot of Medicaid payers, managed Medicaid payers, and Medicare, if you're in a rural health professional shortage area, that Qcode does come into play and is really great and enables more financial feasibility.
Thanks, Parker. You know, one of the questions that I get more and more are rural health clinics or federally qualified health centers, and how do they bill? Because it's a little bit different than how a hospital might bill. Do you guys have experience with that?
Yes, we do. We have experience with FQHC billing in rural critical access hospitals. We've worked with a number of our partners are those types of facilities.
Mm-hmm. And then a follow-up, and that's specifically why I asked this question, is the Qcode billed together with the visit, or is it a separate claim? Do you guys want to address that?
I believe it's billed together with the visit, given that it's per encounter. I can send, to whoever that person with the question, an example claim sheet that has it outlined, the Qcode, but given it's per encounter, it is billed with the claim.
Mm-hmm. Typically what I see is that the provider's office bills for the office visit, and then the location, sometimes it's called the spoke, or the distant site where the patient is located, bills that Qcode for the facility fee. With the site that you work with, does the patient site bill for both pieces?
Exactly, Becky. The patient site bills for both pieces, and the Qcode is billed under the facility's NPI, whereas the CPT code, whether it's an inpatient or med management, that's billed under the provider's NPI.
Okay, great. Thank you.
Sure.
All right. Any other questions? So, Parker, I think somebody had trouble hearing you. Could you say that again about how billing happens with you guys?
Yeah, sure. So was it the last point on the Qcode billing and what NPI?
Mm-hmm. Yes.
Sure. So, the Qcode is billed under the facility's NPI number, whereas the CPT code, the service code there, whether it's a 99204 if it's an initial evaluation, or a 99213 or 99214 for a follow-up, those are billed under the provider's NPI.
Okay, great. All right, I think that's all that we have for today. Unless there's anything else you guys want to address.
I think that's it. I really do. If there's any other questions that come in, please, in the next few minutes, let us know. But I definitely appreciate the activity of the audience today. It's always great when we can have a discussion like this. I think the most fruitful part of a presentation here is answering these questions. If there's any questions regarding the presentation, would be happy to share the data. Just please let us know.
Thank you. Oh, and I forgot to ask before we got started, are you guys willing to share your slides so we can put them up along with the recording?
Absolutely.
Great. All right. Well, thank you all for joining us today. Thank you, Parker and Robin, and I'm going to say it wrong. I'm sorry, Jethan,
No problem.
for your time today and all of your generous information. We really appreciate it.
Thank you.
Thank you, Becky. I appreciate it.